All right. Good morning or afternoon, whenever it is you're watching this. This is going to be a little different this year. So, congratulations. You've completed the first 2 years of medical school and you are about to head off into third year. So, this is a radiology lecture. We're going to basically just do chest x-rays and go through some basics and some key concepts for hopefully about an hour, maybe a little less, maybe a little more. Usually, this is set up to be interactive in a classroom, which obviously we can't do this year because of the circumstances. And then we were going to do this interactive through Zoom, and I actually had something come up. So I will be out of town when you guys are completing this. So we had to do recorded, which I don't think you'll feel shortchanged or anything like that. I also want you to, even though I'll be out of town that week, if you watch this and have questions, shoot me an email. In the evenings, I'll be able to check email and respond to you. And if you have any questions, or if we need to set aside a smaller Zoom meeting to go over anything, we can do that. But this is real basic, just how to approach a chest x-ray, and hopefully you'll find it useful and helpful. So bear with me as we get through this. Like I said, bear with me as we get through this. So, all right, here we go. So again, congratulations. And we'll just run through some things here, some patterns, and you'll see my arrow on the screen every once in a while. So let's do it. So this is a normal chest x-ray. Just kind of take a look. We'll go through how to look at that quickly and be able to do that. But one of the best things you can do when you're learning how to read chest x-rays is, if you have the opportunity in a clinic or somewhere to get your own chest x-ray done without having to be a patient, or if you are a patient, you get a chest x-ray done, take a copy of it. You know, in the old days, we used to carry around our films and we could bring a film home and look at it, or look at it wherever. Nowadays, it'll be on a CD or on the computer. But if you ever have the opportunity, get it and look at it, because if every little haziness and every little opacity that shows up when it's your own chest x-ray, you start to notice things in a little bit more detail. And chances are your chest x-ray is normal. So if you take a good look at yours and study it, it's a good place to start with what's normal. So you have to understand what normal is. So that requires understanding anatomy, and then really just looking at many chest x-rays or x-rays for whatever it is you're looking at, imaging. And the more you look at it, the more comfortable you get, and the more you'll understand and recognize normal. And your goal right now should be to recognize something that's not normal. So you look at it and you may not know what it is if there's an abnormality, but you can say, hey, this little thing over here, that doesn't look right. And then you can go explore, find out if it is abnormal, and then if it is abnormal, what it is. So that's kind of your goal in third year. It takes many people or many physicians a while. It'll be probably into your residency until you feel really comfortable looking at chest x-rays. And then when you start to do it every day, it just it's like everything else, it starts to come pretty naturally. So the other big thing is for you guys to have a pattern. make sure you have a pattern when you look at a chest x-ray and you evaluate the chest x-ray. Doesn't matter what your pattern is. You know, the most common when I ask the students, what pattern do you use or have you heard, they hear the alphabet. A, you know, airway, B, bones, C, cardiac silhouette, D, diaphragm, E, and then it goes, you know, 10, 12 letters into the alphabet. And I don't care if that's your pattern. If that's your pattern, do it, or whatever you like. I have a different pattern, and I'll go through that pattern in a little bit. But whatever your pattern is, do your pattern and do it the same way every time. Even if a big mass jumps out in one of the lung fields, stick to your pattern and wait till you get to that finding so you don't miss anything. What seems to happen a lot of times is when you look at one, if you jump straight to the abnormality, if there's an obvious abnormality, then you'll miss some secondary finding, which may or may not be more important. If you jump to the big mass in the left upper lobe and say, oh, there's a lung cancer, and then you skip your pattern, you never look at the diaphragm to see if there's free air. And what could kill them today versus what may kill them in the long term. If you miss that free air, that's an urgent, emergent problem. And so you never want something like that to happen. So have a pattern and go through your pattern. That is the biggest thing I want you to take away from this lecture. So always check and make sure the patient's name and date of birth, medical record number, whatever else is identifying. So if you're looking for Mrs. Jones, make sure it's Mrs. Jones and not Mr. Jones or a different Jones. So always at least 2 identifying factors, and then look at the film. In most instances, it'll be up there, but is it a PA? Is it a lateral? Is it an AP or whatever it is? So if you start with that, then you'll be on the right track. And I'll give you a couple more as we get further on into this. So the next thing, I want you to evaluate the quality of the chest x-ray. So this comes down to penetration or exposure. So what that is the x-ray beam is shooting these photons through the person, through the chest, and there's a detector plate behind it which it is hitting, and that is what develops into the image we see. In the old days, there was a film like a camera, and you shot the photons through. The photons either passed through or didn't pass through, and then all variations in between depending on the tissue substance. And when the photon hit the developing film on the back, then if the photon passed through, a chemical reaction occurred with sodium and bromide, and you ended up with a dark black spot. If 0 photons passed through, ended up with white. And then obviously you can imagine as you shoot photons through tissue, there are different varying amounts of photons that are passing through. And so none passing through like bone versus a whole lot passing through like lung, which is mostly air, you get, and then you have everything in the middle, you get your varying shades of gray and your image based on how much of the photons and the energy that pass through. Nowadays it's different. There's a developing film, but the photons pass through and it's all digital, and it still happens the same way, the amount of photons that pass through. So if you know that photons passing through hit the developing film or the digital plate behind the patient, turns dark. So an overexposed or an overpenetrated film will be too dark, too black. An underpenetrated film would be too white. And it doesn't mean that it's totally not useful. It's still useful. It just means that the quality, it may not be as useful as a better penetrated film. Nowadays with the digital adjustments, this can be sometimes fixed quickly or easily without repeating the chest x-ray. In the past, the x-ray tech, if it came out poor, they'd have to reshoot the film. Nowadays, there's a lot of adjustments that go through, and this is all done by the x-ray tech. A good x-ray tech will look and say, that's a poor quality, I need to repeat it, or that's a good quality, let's go on and keep moving. So hopefully you will you will not have to deal with that. But you can look, a lot of times body habitus will affect it. So for instance, the X-ray tech, if it's a lineman for the Tennessee Vols or the Tennessee Titans, they're going to be much larger than, you know, a 90-year-old fragile patient who may be thin and emaciated. So obviously you turn up the energy on the photons going through on that larger patient, and you may have to turn it down on a smaller or thinner patient with less tissue. And that's all up to the X-ray tech to do. But it's important for you to look and evaluate, hey, that's a poor quality or a good quality film. Also, I want you to look and say, is this a PA or is this an AP? So anytime you have the opportunity, you always want to order a PA and a lateral if all things are equal. So if somebody comes into your office or the ER or somebody's in the hospital, if they're mobile and they can do it, do a PA and a lateral. Obviously, there are going to be cases where you can't. So if it's trauma or if the patient's intubated in the ICU, then maybe an AP is what you get. But if you have the choice, you go PA and lateral. And one of the main reasons I want you guys to think about is because of the heart size, not the heart size, but the cardiac silhouette. So these two images this is a PA and this would be an AP, and there's differences, and clearly you can see that this one on the left of the screen has better resolution, better detail. So the biggest thing about a PA and AP is about the size of the cardiac silhouette, and that makes sense for you. The truer size of the cardiac silhouette, and usually this isn't that big of a deal, but the truer size of the cardiac silhouette is going to be in the PA versus the AP. So in a PA, posterior anterior film, the photons are passing from the posterior through the anterior, and the anterior chest would be up against the developing plate. So the film, or the photons pass through the posterior, then through the anterior. And it's the opposite in an AP. So in an AP, the back will be up against the developing plate, and the photons will be passing through the front into the back. So if you just think about shadows when you were a kid and think about the light being the photon beam and the wall being the developing plate and your hand being the chest of the patient, if you're making a shadow on a wall, where is the shadow the largest? If you move your hand away from the wall toward the light source, there's more dispersion of the light, and so the shadow on the wall ends up being larger. And if you move your hand back to the wall, there's less distance for dispersion of those photons being blocked. And so as you move the hand closer to the wall and creating a shadow, it becomes more true to size. And that's the same with a PA and an AP. So if we're doing a PA, our chest is against the developing plate and the photons are passing from the back through the front, and our heart is more of an anterior structure. So our heart is closest to the developing plate. So because of that, there's less room, less distance for those photons to disperse and spread out, and you get a more accurate idea of the size of the cardiac silhouette. As opposed to an AP, our back is against the plate, photons pass through, they're blocked, some are absorbed by the heart, keep going, and they get to disperse out. And so you get slightly enlargement of the cardiac silhouette in an AP and a PA. So let's go back to that real quick. So the first thing I want you guys to do when you look at a chest X-ray, or any film for that matter, is go through what I just said. This does a few things. You'll be nervous the first time you'll be in a group on wards, in not too far away, and your patient will have a chest X-ray or any type of film, and the attending or the resident may say, "Hey, so tell me what you see." And since you're new at this, more than likely you're going to get nervous if you're like me at the beginning and you kind of just tense up and, oh my gosh, what do I say? Well, so go through your pattern. Take a deep breath. First thing to do, this is a key little trick, and it buys you time, because the first couple things I give you can't be wrong if you can just read the film and evaluate the film. So Oh, there is one other thing. I want you to look at the rotation of the film. So the rotation of the film, and then we'll come back to what I was saying. So my apologies. So look at the clavicular heads that you see, and then look at the spinous processes. And the clavicular heads and the spinous process, the two clavicular heads should be equidistant from the spinous process. If they're not, there's some rotation. So you can imagine if you're shooting somebody straight on and they're not rotated, clavicular heads will be equidistant from the spinous process. If you rotate, for whatever reason, the patient is, has some scoliosis or something, then you can imagine the angle that that was coming in at, and one of those clavicular heads will be projected closer to the spinous process. So you can then evaluate the chest X-ray to say if it's good position or if there's rotation. And I will try this just to see. So we see a clavicular head here, and we see, looks like a clavicular head kind of there, and here's our spinous process. So pretty equidistant, not too rotated. So, all right. So the first thing you do, somebody asks you to read a chest X-ray or any film, go through these things because you're going to get nervous. So go through these couple things first. Identify the patient, make sure it's the right patient, with 2 identifying factors, and then name the type of film it is and the location, if it's a PA or an AP of the chest, and then go through the quality of the film. So what I've told you is the exposure or the penetration and the rotation. So if somebody were to throw a chest X-ray up as you're buying your time and kind of thinking as you get nervous, and they say, "Hey, student doctor, what's your patient's chest X-ray look like right here? Read it for me." And you can buy a couple of seconds by going, "Okay, well, we have a chest X-ray from Mrs. Jones, and this is a PA chest film. The exposure, penetration seems adequate, and there's no significant rotation in the chest film." And then you can get on to your findings. But that does a couple things. When you do that, that buys you some time, and it also makes you start off sounding like you really know what you're talking about and really confident. So always start off that way. Another thing to look at is to make sure you have the entire area. So you want to make sure you see the costodiaphragmatic recesses. This one's cut off a little bit. So you probably want to say that too in that preface to the reading of it. There's the entire right costodiaphragmatic recess is not included in this image. Then you can get on to the findings. So start all your chest X-rays off that way. It'll make you look really good, and it'll buy you some time. So here is the way I scan the lung fields, and then we'll go back into how I read a chest X-ray when we get to some cases in a minute. And you can use my pattern if you want, but you don't have to. But here's how I scan the lung fields. So I always look at the periphery of the lung fields like you have it here. And then to look at the actual lung fields, I scan my eyes in a zigzag pattern like this. And then when I get to the bottom, I come back up. So then I'll come back up and scan it in the opposite way. So if I've done that twice, 2 scans down, then I should have covered the entire lung field in that zigzag pattern. Then I jump over to the other lung field and I do the same thing. Red line in a zigzag, and then come back up in a zigzag pattern. So if there's any masses, if there's any nodules, if there's any densities or opacities, that should pick up. So that's the way I screen the lung field. Lateral, here's an image of a normal lateral, but it's the same way. So I screen the peripheries like we see here in the red line, and then I screen the entire chest cavity in the zigzag pattern, and then I come back up in this as well, and top to bottom, and I should have seen everything. So there's a couple other things I want you to be aware of before we get to looking at some actual images with some diagnoses, and that's what's called the silhouette sign. So in radiology, this is where the anatomy comes into play. If there are 2 structures, keep in mind, we're dealing with 2D images, but we're trying to get a picture of a 3D chest. So if there are two images in the same plane, we don't have that depth perception. So a little trick when we look at the lung fields, and I have an image to make this a little more clear. So the right middle lobe is adjacent to the right heart border. So any process going on in the right middle lobe will obscure that heart border, and you won't be able to see a defined line. If there is a process going on and it's not obscuring that right heart border, then it is not in the right middle lobe. If it's in the region to overlap the heart, if you can still see the outline of the structure defined, then whatever process is going on is not in the structure or the anatomic location that is abutting up to that other structure. So I have some examples to go through that with you, but here's some things to keep in mind: the left upper lobe and the aortic knob, and then the lingula here, left lower lobe with the diaphragm, and the right lower lobe with the right diaphragm. Again, right middle lobe, this will be the most useful and the easiest to understand, and then the right upper lobe with the paratracheal stripe here that we'll see. And so this is, if you remember the anatomy, this is where this can kind of come in handy. But so looking anteriorly, 3 lobes on the right, 2 lobes on the left. And looking posteriorly, we will only really see the 2 lobes because that middle lobe on the right is anterior to the lobe on the left, or to the lower lobe. And then likewise on the right, you can see the 3 lobes and the 2 lobes laterally on the left. So here's how they come out. Remember, way back to anatomy. And this helps in a couple things. It helps with that silhouette sign, which helps with location. So you can imagine how if there is a mass just right in the mid zone of the lung, on the right, it could be anywhere, just depending on how anterior or posterior it is. If it's here, that's middle lobe. What if it was just right here? That could be upper lobe, or just right here, it could be lower lobe. So it makes a big difference. And so it's another reason why lateral is extremely important if you can get one. And then it's also, again, because of the silhouette sign, you can imagine if the heart was sitting here, that right middle lobe is abutting that heart border. So any process going on here that abuts the heart border will obscure that heart border. And again, I know that's a little confusing right now, but I have a couple cases that'll hopefully explain that a little better for you. So, all right, here we go. So pretty much a normal chest X-ray. So if I were approaching this, I would name the patient. This is a PA and a lateral, which should be labeled, of Mrs. Jones. The penetration is good, not significantly rotated. And we can see that here. Get my pen to work. So we can see not significantly rotated. So here's the clavicular head, and here's this clavicular head, and pretty close to equidistant from the spinous process. So not significantly rotated. Penetration's good, not significantly rotated. We are, and the way this image is, we're clipping the 2 costodiaphragmatic recesses. So slightly limited then. Then I would get into the findings. So the way I do it, I'll use the, let me erase these 2. And then I will walk you through how my pattern is. So after I do all that, then my eyes will scan. And again, if you want to use ABCD, go ahead, just have your pattern and use it. So I bring my eyes down the midline, and I'm kind of just scanning the midline. And again, this goes real quick. And what that allows me to do is look at the midline structures, look at the pulmonary hilum, look at the aorta if there's there, to see if there's anything. And then my eyes scan along the diaphragm, get down here to the costodiaphragmatic recess, and then back up the pleura of the lungs, and then back down here. And then I come over here and I'll real quickly scan that again, and then do the same thing at the periphery, and then back here. And so that's allowed me to see a couple of things. So At the diaphragm, I'm able to see if there's any free air. If there's any free air, it would show up below the diaphragm, which would be important. I can evaluate how sharp the costodiaphragmatic recess is. We want to see a sharp pointed costodiaphragmatic recess, and then scan the periphery very closely to see if there's any pneumothorax. And the same thing on the other side. Then what I do is I scan the lung fields in that pattern I told you. So my eyes are scanning back all the way through the lung fields, all the way through that costodiaphragmatic recess, and then back up in the opposite manner. And then all the way through the apices in the top. And then I do the same thing on the other side. And so I've looked now at the bulk of the chest X-ray. By doing that, I've gotten airway, I've gotten the midline, the pulmonary hilum. I've been able to see the cardiac silhouette. I've been able to evaluate any free air, any pneumothoraces, and then the lung parenchyma. And then after that, I just come back. You're responsible for everything on the film. So even though it's a chest X-ray, you're responsible for down here. And given the way it's usually shot with the energy and the photons, you can seldom see anything down here. But if there is something peeking its little head, you don't want to miss that. So then I look down here, stomach bubble, and in the abdomen, and here would be the liver. Make sure there's nothing obvious, and then glance at the bones. And I look over all the bones to make sure there's no fractures or any type of traumatic injury, and then look at whatever is involved up at the top of the film. So anything in the neck. And likewise, I do the same thing on the lateral. So the first thing I look at on the lateral will be the outline of the heart, or I'm sorry, of the lung. That doesn't look like it, but make sure that costodiaphragmatic recess is sharp. The lateral for me is less useful for picking up on things, but occasionally you can. Really helpful for locating. And then I scan like I did before in the zigzag pattern, all the way from the top to the bottom and then back up. And that allows me to see if any densities poke out. You'll see this increased opacity here, which is the heart. Here's the pulmonary hilum and the mediastinum. And then if there are any nodules or masses, they'll show up. And then the last thing I do is I look at the spinous processes and I follow them down. And I do that because there's something called the positive spine sign. So if you, let me get this. Okay. So if you look and follow the vertebral bodies posteriorly, coming down from superior to inferior, they are whiter or more opaque superiorly, and they kind of fade and become less white as you go inferiorly, and that is normal. So if at any point you start to see decreasing whiteness, oh, this one got whiter, and then back to decreasing whiteness, there is something going on behind that vertebral body that you're not picking up. And that's called the positive spine sign. And I've got an image later on to show you that and make that look clear. So that's the way I go through reading the plain films and the X-rays. So again, if you want to use that one, use it. If you want to use yours, that's fine too. Remember, the point right now at your stage is to know normal, know your anatomy, and just go, hey, that doesn't look right. Not necessarily to have a diagnosis. So this is usually where we would do the interactive and call out, but I will just run through the films for you and tell you what I find for COPD, and hopefully a lot of this you will already know. So again, I know I'm going, for the sake of time, I'm not going to go through the same pattern that I always go through, but this is a standard textbook image of COPD or emphysema. So you've got that long-term smoker. They're usually barrel-chested. And on a PA, you're going to see that they're hyperinflated. Inflation is another thing you can look at. And you want to see about 10 to 11 ribs. Sometimes people can be underinflated. And a lot of times it's either due to they're sick and they just can't breathe in, or sometimes their body habitus. It's really hard for them to take and expand their lungs. And sometimes they can be hyperinflated, such as the case with emphysema or COPD, and they air trapping, and it results in barrel chested. So here we can see the 12th rib down down here, and down here. And usually you want to see 10 to 11. But once you see more normal, then you can just look at this and go, yeah, that's a hyperinflated chest X-ray. So in this one, the findings for COPD or emphysema: hyperinflated lung fields, some flattening of the diaphragm because of that hyperinflation of the lung fields, and the heart seems to be a little elongated, or almost like you just took a string and pulled it down. And again, that's due to the hyperinflation of the lung fields. So this is just a typical case of a guy who's probably been a smoker, or a girl, just a long-term smoker with emphysema, COPD. Usually the case. Again, you're aware there's many other cases that are many other things that can result in emphysema, but most common in our situation will be those smokers. So that's a COPD. Here's the case. So I think everybody can look at this after you go through your pattern and you're scanning your lung fields. You see this opacity. So this is an infiltrate. And then the next question is, well, where is the infiltrate? And again, you should have a lateral, hopefully, to confirm that. But looking at this, you should be able to tell exactly where that infiltrate is. And so a lot of people will look at this and say, well, that's right middle lobe because it's in the middle. And you're right, it's right middle lobe, but not because it's in the middle. So this is where that silhouette sign that I was telling you about, that was probably a little confusing. So anything that obscures the right heart border will be in the right middle lobe, because that right middle lobe of the lung is sitting adjacent to and in the same plane as that right heart border. And when it sits in the same plane, it'll obscure that line. So you can see, you cannot tell that if I asked you to take a pencil and draw that right heart border, you can't definitively say, hey, here's that line, like you could over here. So that's what the silhouette sign is. So this pneumonia, this infiltrate, is silhouetting out the right heart border. So that means it's in the right middle lobe. Sometimes you can get a pneumonia right around here and you don't know if it's in the right middle lobe or the right lower lobe. Well, if it's obscuring the right heart border, it's in the right middle lobe. If it's obscuring the diaphragm because of its position, it's in the right lower lobe. So this is a great image of a right middle lobe pneumonia. Use the term infiltrate or opacity. That's good terms to use. So here we have a nodule. So what's the difference between a nodule and a mass? So generally speaking, a nodule will be less than a centimeter and a mass will be larger than a centimeter. So right here, everybody can see, there is our nodule. All right, so where is that? It's on the left. So if this were shown up for me, let me erase that. All right, so if this were shown to me, we have a nodule on the left. I would use the term mid-lung. We don't know if this is going to be the upper lung or the lower lobe. This could be the lower edge of the left upper lobe, or it could be the upper aspect of the left lower lobe, because remember, they overlap like this. So we don't know where we are. We need the lateral. So if we don't have that, then if you use the term that's in the left mid lung or the mid zone of the left lung, then you're accurate. If you say left upper lobe, you could be wrong. If you say left lower lobe, you could be wrong. So we get the lateral, and the lateral will help us. So here we see that nodule. And it's clear now because it's anteriorly that it's in the left upper lobe of the lung. So nodule less than a centimeter or less, mass greater than a centimeter. And then here's a good example of how to use just some terminology to describe the location. So here's a difficult one. If you just take a look at the PA first, you really don't see anything. Which would be normal, but there's something hiding back here. And here is sort of the example of the positive spine sign that I told you. So if you were just if everybody can see, right here is a mass. So you can see that mass. Let me erase that now. So everybody see See the mass back here. So if you just move that mass a little bit posterior, you can imagine how it would be more opaque or wider back here. And that would be an example of the positive spine sign. You see it's more white, getting less white, and then boom, if this were a little further back, that would be a great example of a positive spine sign. There's also a great example of how things can hide behind other things. So the heart is probably obscuring this mass. So we have a mass back here that we could just say is in the posterior mid lung. We're not sure which one it's in. In hindsight, it is more than likely over here in the right, but we don't know that for sure. But that would be my guess. It's a little opaque. So after seeing this, we can come back over here and say, where is it? And say, we think it's in the right, right there. So that's a good example of the positive spine sign. Sometimes infiltrates or pneumonias will present that way and show you that positive spine sign. All right, atelectasis. So atelectasis is where there is collapse of some of the alveoli, oftentimes due to being hospitalized, not being mobile, not taking in big, deep breaths and getting those alveoli to expand. And there's a couple different forms of atelectasis. This is one form. But you can see here, you can clearly see that the right diaphragm is just fine and the right heart border is just fine. If this were an infiltrated pneumonia, it would be obscuring one of these two, depending on if it was in the middle lobe or the lower lobe. These are harder. The atelectasis is harder to see. That's kind of a more advanced topic, but usually these patients will present with like a low-grade fever, oftentimes after surgery, and it's just because they're not mobile. Nowadays, I'll have them breathing, doing spirometry to just open up those lungs. So this is the one of the more harder ones, but you should be able to say, hey, there's something going on in the right lung, and it's not an infiltrate because I can see that right heart border and that right diaphragm, and so this is an atelectasis. Curly's B lines for you guys. I just put this in there because everybody likes to ask this, or at least when I was a student, they would throw up a chest X-ray and say, hey, what are these things out here? And so these are short, less than a centimeter linear kind of parallel opacities out at the periphery. And usually they're in a patient that's in CHF or volume overload. And that's just congestion of some vessels out here at the periphery. And usually there are many other findings that you can see in the rest of the film to tip you off that the patient's in CHF or pulmonary edema, but it's just one of these things that, at least in my experience, people always like to ask and just see if you know what they are. So those are Curly B lines. So this is an example. We have severe opacity of both lung fields. And if you use your imagination, you could almost say that it's expanding from the mediastinum right here and expanding out. Before it got this severe, it would probably look or be reminiscent of a bat wing, if you recall that. So this is severe pulmonary edema, interstitial infiltrates, and there are two different types of infiltrates. There's alveolar infiltrates, and then there's interstitial infiltrates. So the alveolar infiltrates are in the alveoli. The interstitial infiltrates are in the interstitium of the lung. And that is one of those things. It is just really hard to, it takes a while to get an idea of what's interstitial and alveolar. Alveolar is kind of like, looks like a cloud if you were looking up in the sky, or cotton candy, some people say. Interstitial is usually a little more nodular. Don't worry about that. The more you see and the more you do, then that'll become second nature to you. It's just one of those things that's very, very hard to describe. But in this case, you can see extensive infiltrate in both lobes of the lung. And you start to get this reticulonodular opacity up at the top here, and those are just congested vessels. Here's a patient post-op. We see these sternotomy wires in the midline. So Dr. Fite or some cardiothoracic surgeon was in there messing around. And then we start to see blunting of the right and the left, so bilateral blunting of the costodiaphragmatic recesses. So this is pleural effusion, and we can also see blunting of the costodiaphragmatic recess on the lateral posteriorly. So this is an example of bilateral pleural effusions. You'll see that a lot. And here's just a CT scan showing you, again, the fluid back here layering posteriorly in a patient that's supine in the CT scanner. So subclavian, so here's a case we're gonna say, hey, you just did a subclavian line, or somebody just did a subclavian line, and now the patient says, hey, they're short of breath. So keep in mind, as you're going for that subclavian, if you're a little off, here's the pleural space in the lung. So you can imagine a couple of things can happen. So obviously you always forgive the misspelling of subclavian line, but you know, always after any type of procedure that could result in any type of pneumothorax or anything like that, you get a chest X-ray. So this might be a case where a few hours later the nurse calls and says, hey, your patient's short of breath. So you get a chest X-ray, take a look, and there's this opacity in the right, and you happen to have done the subclavian in the right. So in all likelihood, this could be a number of things, but in all likelihood, given that somebody was just poking a needle in there and into a vessel, this is fluid. So this is a unilateral effusion, and it's probably blood if you were sticking a needle into the subclavian artery. So this would be a hemothorax, unilateral, again, because that's the side you were on. Other issues that can happen with subclavian lines or a pneumothorax, these can be extremely subtle and extremely hard to pick up. So you'll miss one, you'll miss a small one in your career. It just happens because of the lines and how subtle they can be. What you don't want to do is you don't want to miss a big one that's going to kill the patient or take them south quickly. So there should be on the PAC system, which is the system that you'll pull up, the computer system that you'll pull up to see the imaging and the chest X-ray. And when you go pull it up, after looking at the chest X-ray, there should be a key that has a little magnifying glass on that system. And you can click on it and then move your cursor over areas, and it'll magnify that little area that the square is over. So I encourage you in every chest X-ray you look at to do that magnifying glass and then move it along the periphery of the lung out here. And that'll help you pick up a pneumothorax. So you should see lines and vessels extending all the way out to the periphery. And you should not see any straight lines. If you see a straight line like that and no vessels are extending past it, then the chance you have a pneumothorax is pretty good, and you want to look really close at that. So here's the dreaded tension pneumothorax. So here's a complete blackout of the lung on the right. No markings. That lung has been compressed, and you can see it right here. So here is the lung that's been compressed. You can kind of see it up right there. So no lung markings out here. So that lung has been completely collapsed, and then it's under tension because you can see the heart, the airway has all been shifted to the right. So this is a tension pneumothorax. So tension pneumothorax, sometimes you can have it under tension, sometimes you can't. But anytime they get this large, usually a tension pneumothorax. And then here's just a CT scan to show you that compressed lung. And then everything, airway, heart, everything shifted over to the side. Just interesting. Sometimes you'll see things that that aren't supposed to be there. And here is just an example of a cervical rib way up there. So just an interesting finding. May present, may not present with anything, may be incidental. I had a case when I was an intern in Memphis, and the young softball player, high school girl, came in, ended up with a thrombus, a DVT in her upper extremity, really rare. So you do the whole workup when a young female presents with clotting, hypercoagulable state with DVT in her subclavian artery, and on chest X-ray, she actually had a cervical rib that was causing compression on the artery, which then set her up to have this clot, given her so much, overuse being a softball pitcher. So sometimes you'll just pick it up and say, you got a cervical rib, big deal, go on. Sometimes, like this softball pitcher was, it may result in something. So just a neat little case there. All right, so a lot of people will look at chest X-rays and say, hey, the heart's enlarged. And 99 times out of 100, probably even more than that, if you say the heart's enlarged and the outline of the heart is larger than it's supposed to be, then you will be right. But occasionally you won't be. So first of all, the cardiac silhouette. So if you were to look at the cardiac silhouette and eyeball it, it should be less than half of the hemithorax. So I'll draw that out for you. So you would want to eyeball, and sometimes we'd use our finger on the PAC system just to use a measurement of how it is. And then this distance here, you would want to be less than half, or I'm sorry, less than this distance. So you want the distance of the heart right here to be less than a hemithorax. So come to the midline and come here, and hopefully that lower line should fall within this one. If it doesn't, then that cardiac silhouette is enlarged. And I use the term cardiac silhouette because most time it is the heart enlarged, most times it is cardiomegaly, but you could have other things going on, like you could have a pericardial effusion. And so the heart is not technically enlarged, it's the fluid around the pericardial sac that is causing enlargement. And so I would encourage you, even when you think it's cardiomegaly, you just say, when you're looking at a chest X-ray, there's enlargement of the cardiac silhouette as opposed to cardiomegaly. And then here with the cardiomegaly, this is much more globular, balloon shaped. So this is probably a pericardial effusion. It may not be. You have disorders where we can see enlarged in hearts like this. So this is one, could be pericardial effusion, could be something else going on. So enlargement of the cardiac silhouette. Here's another type of atelectasis. So I'm jumping around on you, but it's called platelike atelectasis. And this is usually just people who aren't ventilating well. Maybe they're not taking deep breaths. Maybe they're on a vent. Maybe they're post-op and they're just not able to take a deep breath and expand. And it's called platelike atelectasis. And you see these little plate-like linear densities down here. And again, that's just alveoli, subsegmental alveoli that aren't filled with air, and they're kind of flattened. This is another one of those things that's harder to see, and the more you see, the easier they'll get to see. And a lot of times you'll just put the history together and say, well, that's what that line means, or doesn't surprise me that the patient has this. So this is plate-like atelectasis. Free air is an emergency. So in that scan, you come down, you look at the diaphragm. You want to make sure the diaphragm's smooth, no effusions, and you want to make sure there's no free air. And we can see free air right here, right above that. And we can even see some free air here, right above that line. So here's the stomach bubble. So you can see the stomach bubble. So don't confuse that. So there's our stomach bubble right there. And then let me change the color. And then in the blue right here, you can see this free air. And you can see a little free air right here and a little free air right there. So again, something in the abdominal cavity has ruptured, produced some free air, and that's usually an urgent, emergent type of situation. So when you start to look at, or when you start to look at the diaphragms, always look for free air when somebody comes in. Now, if they've had surgery and a surgeon's been down in the abdomen, you can expect to see some free air because intra-abdominal air got in there if there was a laparoscope or a surgery. But if somebody comes in off the street or has no reason to have free air, you need to really worry about a bowel perforation. Here's another example, not the greatest film, but you can see much more free air over here and over here. So kind of wrapping it up a little bit or getting down toward the end, we're going to talk about tubes and lines. And this is another one of those things at the very beginning you probably want to identify, not at the end like I did here. But when you're walking through, this is a PA chest X-ray of Mrs. Jones, and there's good penetration. There's no significant rotation, and it's an adequate film. Then you also want to, the first thing you probably want to do before you look at it is identify all the tubes and lines. So some of the more common ones we'll go through. So here's an endotracheal tube. So you'll see lots of these, and these are able to be identified by this line. You see this thin line here, and that should be the tip of the endotracheal tube. So you can see it right there, and see the arrows pointing to it on this magged up view. This would represent the carina, and you want the tip of the endotracheal tube to be 1 to 2 centimeters above that carina. So this is what an endotracheal tube will look like. Now this is what an endotracheal tube that has gone down the right main stem will look like. You can see here, I would say this is probably the carina. So we really want that endotracheal tube up here. So no big deal. Somebody has just advanced the endotracheal tube too far, and it's gone down the right main stem. So I say no big deal, but it is a big deal if nobody takes a look at the chest X-ray after placement of the endotracheal tube, because now only one lung is being ventilated, and this lung is being left out. So all that needs to happen is come back, pull that endotracheal tube back a couple centimeters, repeat the chest X-ray, and try to get that tip right there. So here's intubation of the right main stem bronchi with endotracheal tube. Here's a nasogastric tube, and the way to identify the nasogastric tube is this right here. So you see this density metallic at the end of a tube coming down, and that's what helps you identify a nasogastric tube. So given that, you can appreciate that this nasogastric tube is not in the stomach, right? So the nasogastric tube should go down midline, come down here into the abdomen, and then go into the stomach. We see the stomach bubble over here. And what happened is this is in the right main stem, so this is in the lung. You put in enough nasogastric tubes, this is going to happen. No big deal. That's why you get a chest X-ray afterwards. Pull it out and then go try again and make sure you're down the oropharynx and not the bronchi in this nasogastric tube. So here's a central line. So you see coming down from the IJ into the right heart, and then into the right heart. So we see the end here. It's probably in the right ventricle there. So just make sure you can identify central lines. And then here's a Swan Ganz, and we see the tip of the Swan Ganz. So it's come down, looped around, coming out the right main stem, and we see it probably at the right, at the hilum of the lung. And then eventually you would advance that Swan Ganz out to get the readings out here, the pulmonary capillary wedge pressure. So you'll see those, especially on the unit. And then here's a defibrillator. This patient's had a median sternotomy. You see the sternal wires here from after his chest was cracked open. And then you can see there's a defibrillator placed, and this one is a dual lead. So you can follow that lead around, and then this lead's coming down here. So you just want to identify those, make sure the pieces are where they should be. You want to make sure, say one of these tips hasn't freed up and is in a location that it doesn't need to be. Real quick, some abdominal films. So this is what a small bowel obstruction would look like. And you see the dilated loops of small bowel all on each other. And some people say they look like a stack of coins if you were to see the line and the markings in the dilated loops of bowel. So that's what a small bowel obstruction would look like. And then here's what more of a large bowel obstruction would look like. And you see some air fluid levels and dilated distended colon here. And then this is what a volvulus would look like. So y'all remember what a volvulus is, and it's almost like a horseshoe upside down. That's sigmoid volvulus, air distended because of that. So that will cover this radiology session for transitions. Here is a great little resource in your time if you want. This is University of Michigan has an app for your phone for radiology, and they're basic and they're really useful, and you can just kind of do in your spare time when you're just kind of chilling or watching TV. So it'll walk you through some things, a lot that I went over, but some other things as well. And that would be a great resource as you're trying to learn and understand imaging and particularly how to read chest x-rays. So if you guys have any questions, reach out and email me. You know my email, it's denham@etsu.edu, and I will try to get back to you. If you have any other questions or anything like that, please reach out, and congratulations and good luck. You're all going to do fine. So good luck, and I know you guys are excited for third year.